cellular environment, like before the drug enters the cell, the brain cells, the epithelium of the blood-brain barrier, like the environment should be suitable, like it should not be alkaline. Like if you're giving an acidic drug, like barbiturates, then the environment nearby should also be neutral, or like, of course, neutral, not alkaline, for the drug to be non-ionized by the time it reaches into the brain. Then, of course, the pKa, like for this, like if the drug has a low pH, then like the environment should have a neutral pH. That means the pKa of the environment should be the opposite of the pH. You get what I'm saying? Like if pH is low, pKa should be high. Okay. Then lipid solubility of the drug, that most like because like the cell membranes in the body are lipids, right? So like for the drug to be correct, then that means it should have a good lipid solubility for it to easily cross over. Then speed of injection. Rapid IV administration results in increased initial concentrations of the drug and CVS and respiratory side effects. I think that you've understood. So then we have distribution to other tissues. Anesthesia takes place after one arm brain circulation, like I think like after one cardiac cycle. Yeah, that's when the anesthesia will start. So yeah. Then the anesthetic effect of IV anesthetic drugs is terminated predominantly by redistribution. This one I explained. Like firstly, that the drug will move to highly perfused tissues. Then it will move to less perfused tissues. Okay, like it will be redistributed and therefore metabolized in those tissues. And then like its effects will run out. Metabolism of most IV anesthetic drugs is predominantly in the liver. Then classification of intravenous anesthetics, we have the rapidly acting like agents, and then we have the slower acting agents. The rapidly acting agents, we have barbiturates, where we have methotrexate and thiobarbiturates like thiopental and thiamlal. Then we have etomidate and propofol. These are rapidly acting. Then the slow acting ones, we have ketamine, benzodiazepines, large dose opioids, and neuroleptic combinations like opioid plus a neuroleptic drug. Neuroleptic malignancy. I remember I did today, like when I was reading this. Anyway, side note. So we have barbiturates. Barbiturates have a barbituric acid ring. I tried to get images of that ring, but like this is what I could get. Remember, like our benzene rings, like we have a carbon compounds, like where you don't see anything, like here, like we have carbon molecules. Then we have now, you're supposed to have 3 oxygen atoms attached, plus 2 nitrogen hydrogen. What's this? What's NH? I've forgotten. Like in chemistry, NH. I think it's an amine or an amide, right? Okay, like an NH, you're supposed to have 2 of those. One N and an H. So it doesn't matter like how that shape is, as long as you have those 2, like 3 oxygen atoms plus 2 NH molecules. That's how the ring looks like for barbiturate. So, and they said here that we have 4 groups of barbiturates. We have oxy barbiturates, methyl barbiturates, methyl thiobarbiturates, and then thiobarbiturates. So, but like when I was reading somewhere else, they said that we also have okay, but here, let me first finish this. And then he said that only the oxybarbiturates and the thiobarbiturates are used. And the most commonly used barbiturates are thiopental, methotrexate, and thiamlal. So, but like when I was reading somewhere else, like in the classification, they said that we also have like in the classification of the barbiturates, we have the ultra acting barbiturates is within seconds, and the duration of action is 30 minutes. Like maximally by 30 minutes they are done. Like the effects are worn out. And these include methohexital, low sodium, and sodium. I think that's why he gave us those examples because, like, when they said that only the acting ones are used as anesthetics. Mm. So, we also have the short acting and immediate acting and long acting barbiturates, like in the classification, but only the ultra short acting are used as anesthetics. Are we together, people? Yeah, but
Trying
like
to
I
be
said,
together, but
these
network.
yeah, they induce, then you have to give maintenance drugs and mostly maintenance drugs. No, maintenance drugs will give the volatile drug, the inhalation of anesthetics, like sevoflurane, isoflurane, those ones to maintain. But like inducing, no, the IV ones are the ones that induce. That's what I'm talking about now, currently. Then someone talk about the maintenance drugs. So we have thiopentol and thiamlal. Those are ultra short acting. Yeah? Methyl, methohexital. No, these ones like the ones I was giving you, like the classifications. They're not in the slide, but I read them somewhere. So like I wanted to add them in, like as we are discussing. Yeah, and I said only the ultra short acting ones. That's why I said that. That's why he said that most commonly used barbiturates are these ones because they are the ultra short acting ones. They are pentyl, methohexital, and they are amyl. So then he said that having a sulfur atom at position 2 of a barbituric acid ring produces thiobarbiturates and, and results in rapid and smooth onset of sleep, fair and fairly fast recovery. So, and then having an oxygen atom at position 2 of a barbituric acid ring produces oxybarbiturates and results in delayed onset of action and also prolongs action. Thiopental and thiamlal are thiobarbiturates and methohexital is an oxybarbiturate. I tried to get images of this, but like the things were so confusing. So I left them out. So we're going to talk about our first drug, sodium thiopental. So sodium thiopental is an ultra short acting barbiturate, like I said. Ultra short acting barbiturates are the ones we use in anesthesia. Then we have the internet. I think it's back. So we have for induction. I think most people use, I don't know in KIU, but I think most people use ketamine, right? For induction. I think they have all, because in Fort we used to use propofol. I don't know if it was just for the camp, like when those Italian guys came, but they were using propofol. So we have sodium thiopental. It is an ultra short acting barbiturate, yellow powder with a sulfuric smell. And we said that the sulfur molecule, many atom will be found on. Yes. So, yeah. So it is mixed with 6% anhydrous sodium carbonate to increase its solubility in water. I think like this, it will help it for excretion and metabolism because like I think most of these drugs are fat soluble. So they add a water soluble component like to help with the excretion. And they're available in a single dose Ampules of 500 milligrams should be dissolved in normal saline or water for injection to produce a 2.5% solution, and 5 milligrams per ml. Solution pH is 10.8 and the pKa is 7.6. It is bacteriostatic. So like since this is its pH, that means like in the environment around it, for it to reach the brain, the environment around it should be acidic, right? Because the pH is 10.8. Not acidic, sorry, neutral or alkaline for it to reach. Then it is bacteriostatic in water, highly protein bound, mostly to albumin, 75%. Therefore, I think that like that's why the dosage is a bit higher, like a bit high. So like for it to be available enough, because it's highly protein bound, that means like less of it is reaching like in its form. So, and then we have the induction dose, IV dose for healthy adults is 3 to 5 milligrams per kg, and in children it's 6 milligrams per kg, and for the elderly, we have 2 to 3 milligrams per kg. So I tried to look for why the dosage in children is high, but I failed to get any reason as to why. So I guess they did their tests and found that that's the effective dose in children, or children metabolize it faster. I did understand. Maybe. So yeah, I didn't find a reason. That's why I don't have an explanation for that. Then we have it results in loss of consciousness within 30 to 60 seconds in one arm brain circulation. Anesthetic state persists for 5 to 10 minutes. As you can see, like the duration of action is very short. So you have to have given a maintenance dose by then. Then the short duration of action of thiopentol is almost entirely due to its redistribution, and metabolism occurs primarily in the liver. Indications for giving sodium thiopentol, we have induction of anesthesia, maintenance of anesthesia during short procedures. So like you keep giving every after 5 to 10 minutes, you keep giving. Like if you're doing a short procedure of like 20 minutes, let me see. Then treatment of status epilepticus and reduction of intracranial pressures. So sodium, the CNS effects of sodium thiopentol, we have barbiturates interact with chloride ion channels and facilitate inhibitory neurotransmitters like GABA, as well as blocking excitatory neurotransmitter actions such as glutamic acid. I tried to read more about like, the mechanism of action. Yeah, so like as I was saying, like they're saying that they interact with chloride ion channels and facilitate inhibitory neurotransmitters like GABA, as well as blocking the excitatory ones. So like your brain like does not receive the excitatory neurons to act like when you're like in a state of kumbaya. So they do this by binding to GABA A receptors at the alpha beta subunit. Like remember we had that GABA receptor thing that had an alpha, a beta, and did it have a gamma and some other one, right? It had 5 receptors. So like, but these ones they don't bind to the alpha beta subunits because like that's where GABA binds. But for them they bind on the GABA A side. Then like when they bind there, they enhance the effects of GABA, the GABA A binding sites. And hence they increase the ion channel opening duration, like the ion channel, like remember like when you have neurotransmission, you're supposed to like let me say if GABA comes in, then also like if glutamate comes in, the channels will be closed. But now for them, like they maintain that the chloride channels open. So like there is continuous stimulation by GABA, which is the inhibitory neurotransmitter. So you don't have excitation of neurons for that time. You've understood? So they increase the receptors. Therefore, you have inhibitory transmission continuously. You've understood, people? So, yeah, it also has anti-analgesic effects. It can be used to stop seizure activity in emergency situations. I think that's why we said you can give it in status epilepticus. Yeah, it decreases intracranial pressure by increasing cranial. Someone trying to join. I don't know. So, yeah, it can be used to, it decreases intracranial pressure by increasing cranial metabolic rates. Sorry, not cranial, cerebral metabolic rates. Like the guy put CMR, but like by decreasing cerebral metabolic rates and also the cerebral blood flow. So it decreases both. We shall see that there are some drugs that increase both, but like for sodium thiopentol, it decreases, and it also decreases intracranial pressures. So the cardiovascular effects, it causes dose-related myocardial depression by decreasing cardiac output, stroke volume, and decreasing blood pressure. Venous tone also decreases, and baroreceptor inhibition and loss of vagal tone cause modest hypotension and reflex tachycardia. In elderly patients, you reduce the dose by 30 to 40%. I think because like they can't metabolize that. So it can cause like severe effects. No, no, it's not a good, like you can't give it in patients who already have cardiac problems. Okay, like there was like of course like there are some drugs that are safe, like in this for cardiovascular problems, like ketamine is very good, like it does not cause CVS or respiratory depression, but this sodium thiopental does. So like you can give it with caution in certain cardiac diseases, but like if the patient has a severe cardiac problem or they have experienced shock in a short duration, like we shall see like the indications and contraindications. But like if a patient has suffered a shock during that short period of time, like before, you do not give sodium thiopental for that patient, like for induction of anesthesia. Are we together, people? Yeah. So like then respiratory, it causes a ventilatory drive is decreased due to decreased sensitivity of the respiratory centers to carbon dioxide. So it can cause like the respiratory system to also be depressed. It increases bronchial muscle tone and rarely bronchospasms. Laryngospasms are precipitated by the surgical stimulation or presence of secretions, blood, foreign bodies, e.g. Weddell's airway. I didn't understand what LMA is. in the pharynx or larynx. Yeah. So during light levels of thiopentol anesthesia. Then for the skeletal muscles, it causes oh, mm. So it, like when you have those things, like in the air, it can cause laryngeal spasms. Mm. Then skeletal muscle, it causes reduced muscle tone due to suppression of the spinal cord reflexes. So you have reduced muscle tone. Then for the uterus and placenta, it has little effect on the uterus. Like it crosses the placenta barrier. Like it crosses, but it has little effects on the fetus. Like the fetus will not experience that. I think that the side effects of respiratory depression and all that. So hypotension, if you give an excessive dose, if excessive doses are used or in hypovolemic, shocked or previously hypertensive patients, you administer slowly. Tissue necrosis with perivenous injection, median nerve damage after extravasation in the antecubital fossa injection, inject tissues with hyaluronidase, like if you're experiencing damage, like tissue necrosis. Then intra-arterial injection, inadvertent injection. Sorry. Intra-arterial injection, inadvertent injection, patient. What is mm, what is I think the patient complains of intense burning pain, blanching, like you all know blanching, right? Like reddening. Like when you press the place, it becomes white, but when you release it becomes red, blanching. But it's already a bit red. Blanching, blisters distally, stop injection immediately. Profound arterial constriction and local release of norepinephrine, formation of thiopentol crystals in the arterioles. Like it can cause endarteritis, thrombosis, platelet aggregation, emboli, ischemia or gangrene in the forearm, hand or fingers. Like if you give it in the arteries, it's like I think you're supposed to give venous, right? You give drugs venous. Yeah. So, but if you give intra-arterial, you can have all those side effects. And endarteritis, thrombosis, platelet aggregation, ischemia, gangrene of the forearm, hand and fingers. Inject vasodilator in the artery, stellate ganglion or brachial plexus, block to decrease arteriospasms. IV heparin or oral anticoagulants because you're already having platelet aggregation and thrombosis. Then the risk of ischemic damage is much greater with 5% thiopentol solution. Other side effects, we have thrombophlebitis, laryngospasms, bronchospasms, allergic reactions. So we're talking about absolute contraindications. We have in airway obstruction or anticipated difficulty in the airway, e.g. when the patient has epiglottitis, oral or pharyngeal tumors. Then in porphyria, like it may precipitate lower motor neuron paralysis or severe cardiovascular collapse in patients who already have porphyria. Then if there is a previous history of hypersensitivity reactions to a barbiturate. Then precaution, like you can, there are contraindication, but like you can give, but with precaution. We have in cardiovascular disease, if the patient has hypovolemia, myocardial disease, cardiovascular stenosis, cardiovalvular stenosis, or constrictive pericarditis, you administer the drug with extreme caution. if the patient has severe hepatic disease, like you have hypoalbuminemia, and remember we said the drug is highly protein bound. So you have to give with caution because like there will be excessive concentrations of the drug if you give the normal dose. Yeah. Then in renal disease, because like you administer very slowly, I think because like the drugs are supposed to be excreted through the renal system. Then also like in renal disease also have hypoalbuminemia, right? In renal disease. Then outpatient anesthesia, slow recovery, hangover may result in persistent drowsiness for 24, 36 hours. So that patients should be careful not to drive or use machinery. The effect of alcohol or of sedative drugs is increased during this period.